Subscribe now and press the bell icon. Never miss an update.
Welcome you all to introductive session on hepatobiliary system. Today's part 2 session for hepatobiliary system. The topic of discussion is obstructive jaundice. This topic is very important for all postgraduate and undergraduate students because in the long case, in every exam, if patient is available, must begin at the time of examination. So, in toto, discussion needed, but what is about the obstructive jaundice? So, the obstructive jaundice, before starting the obstructive jaundice discussion, first we discuss about the anatomy of the biliary tree. So, if you understand the anatomy of the biliary tree, you can easily evaluate the causes of obstruction, where, how we can easily evaluate. For that, you can look at the picture. This is the gallbladder, which connected with the duct. This is called the common hepatic duct. This common hepatic duct is formed by right hepatic duct, which is coming from right lobe of the liver, and left hepatic duct is coming from the left hepatic lobe of the liver. So from the right and left lobe of the liver, biliary excretions are excreted through the right and left hepatic duct, joined together to form the common hepatic duct. This is connected with the cystic duct and ultimately form the common bile duct. This common bile duct running down and ultimately it enters into the ampulla beta. So there some part is above the duodenum, some part of the common bile duct is behind the duodenum, some part of the common bile duct is below the duodenum, first part of the duodenum, and some part is intramural part of the second part of the duodenum. So the biliary tree consists of the intrahepatic and extrahepatic bile ducts. The right and left hepatic ducts join to form the common hepatic duct, which joins with cystic duct to form the common bile duct. The main pancreatic duct or the duct of Wilson join with the CBD, opens through the ampulla of beta in the second part of the duodenum. Join with the pancreatic duct, it opens the second part of the duodenum. The length of CBD is usually 7 to 10 centimeter in length, average 7.5 centimeter. Length of CBD. That means from the cystic duct joining to the ampulla beta, that area is usually 7 to 10 centimeter in length. And diameter is average 6 to 8 millimeter. 6 to 8 millimeter, that means 0.6 to 0.8 centimeter. 6 to 8 millimeter in diameter. It is the normal individual, the CBD diameter is 6 to 8 millimeter. The parts of common bile duct is supraduodenal, above the first part of the duodenum, along the free margin of the lesser omentum. That means that part lies within the free margin of the lesser omentum. And behind the CBD, there is an opening which connects the greater sac with the lesser sac, which is called the foramen of Winslow, which lies just behind the CBD. Free margin of the CBD, there is an opening which is called foramen of Winslow. The rectoduodenal behind the first part, infraduodenal below the first part, behind the head of the pancreas, and intraduodenal, that is passing through the wall of the duodenum along with the main pancreatic duct in the second part of the duodenum. So these are about the anatomy of the biliary tree. That anatomy is the structure for the drainage system. And another important thing, you look the picture, the blood supply, that means arterial supply of the CBD. So if you look carefully, that right hepatic artery, there is a branch, it's called cystic artery, which supply the gallbladder. But here, the duct is supplied by the lot of branches in interlaced fashions. So it branches coming from the right hepatic artery, branches coming from the left hepatic artery, branches coming from the gastroduodenal artery, branches coming from the retroduodenal part of the artery, and branches coming from the pancreatiduodenal artery. So the CBD is supplied by lot of branches in the interlacing fashion, which is not required for your examination, but it is required for evaluation the anatomy, and during surgery, if you incise, so there is a lot of branches coming from all sides. For that reason, the knowledge is required to know how the blood supply of the common bile duct and common hepatic ducts is. So these are the supplies from the various branches to supply the common bile duct and common hepatic ducts. So obstetric jaundice is also called the surgical jaundice. That means the jaundice, the cause is obstruction, which develops the jaundice called the obstetric jaundice. So it means the jaundice which appears due to the obstruction to the outflow of bile from the liver to the multiple due to multiple causes. So outflow obstruction causing jaundice is called the obstetric jaundice. So there is a picture that stones, this is a bile duct, this is gallbladder, this is a carcinoma of the ampulla beta, carcinoma of the head of the pancreas here, and carcinoma of the common bile duct. If there is so, these are the causes of multiple cause of obstruction. So the causes are divided into three parts. That means the lesion develops within the lumen, which is called the intraluminal. The cause, if lies in the mural part, in the wall, is intramural, or the lesion is outside the lumen. From outside, it compresses the lumen, cause the extramural cause. So the intraluminal cause, the commonest is stone in the common bile duct. Stone in the common bile duct. And another thing is ascariasis. That means helminthiasis. So all individual having to some extent of roundworm inside the abdomen, that roundworm sometimes enters into the ampulla beta, and which causing obstruction of the common bile duct, and the patient may present it as a pain and subsequently present it as a jaundice. For that reason, the interluminal cause is two. One is stone, another is ascariasis. That means helminthiasis of the CBD. The intramural causes are stricture of the CBD. If the common bile duct is narrowed by the lesion in the wall, it means narrowing of the common bile duct is called the stricture. And another cause is sclerosing cholangitis, and another one is cholangiocarcinoma. So these are the causes of intramural. And extramural are carcinoma of the head of the pancreas, periampullary carcinoma, chronic pancreatitis, pressure by enlarged celiac lymph nodes. So the carcinoma of the pancreas, the lesion, that means the malignancy arises in the head of the pancreas. So within the head, the ampulla beta lies, pancreatic duct, and the common bile duct lies. So that causing pressure effect directly over there. And periampullary carcinoma, that the lesion around the ampulla beta, if malignancy in and around the ampulla beta, from the duodenal mucosa, from the duct, lining of the pancreas, from the duct within the common bile duct. So all around the ampulla, which is called the periampullary carcinoma. And another one is chronic pancreatitis. So whenever there is infection, there is inflammation, so there is a fibrosis. So repeated attack of fibrosis causing the narrowing of the ampulla beta due to the pancreatitis, and the patient may develop subsequently jaundice maybe. So which is causing the surgical jaundice, or which is causing the obstetric jaundice to develop. Pressure by enlarged celiac groups of lymph nodes. So that celiac groups of lymph nodes are drained the malignancy from the pancreas, from the duodenum, from the stomach, from the gallbladder. All the malignancy are drained in the celiac groups of lymph nodes. So that celiac groups of lymph node is very close relation with the common bile duct. For that reason, it may keep pressure over there and may causing the jaundice. For that reason, the cause is written here: pressure by enlarged celiac groups of lymph nodes. So clinical classification. The jaundice develop lot of causes, but the jaundice having some nature. That means some jaundice having persistent, there is jaundice. And some patient having the jaundice, sometimes it rises, sometimes it go down, but never ever touches the baseline. And sometimes there is progressive jaundice, increase continuously. With that evaluation of the nature, the jaundice is classified into 3 types, like intermittent jaundice, fluctuating jaundice, and progressive jaundice. So the nature of the jaundice can dictate you what is the cause of obstruction is. So if the patient having an intermittent jaundice, that means the patient having a sharp rise, then sharp fall, touches the baseline. Again, there is a sharp rise. So sharp rise, fall, again rise, again fall. So that is nature is called the intermittent jaundice. So that intermittent jaundice is usually developed in case of periampullary carcinoma. That means in periampullary carcinoma, only there is involvement of the mucosa, and this will be slapped out because the growth inside the lumen. So there is a more pressure effect causing ischemia and causing there is sloughing of the tissues to the duodenum. So the lumen is open, the jaundice become declining. That means and total lumen will be free, resulting in the jaundice-free episodes. Again, there is increased rise. Increased rise due to the growth is continuous process for that. So this is called the intermittent jaundice, which the cause is periampullary carcinoma. But in case of fluctuating jaundice, that means there is a rise of jaundice and again fall, but the fall is not touches the jaundice in the baseline, normal level. Again, rise. So that rise, fall, rise, it is called the fluctuating jaundice. That means the jaundice never fall down and touches the midline and touches the normal level between the falling period. So that is called causes are common bile stones and cholangitis. When the stone in the common bile duct, the common bile duct become edematous and cholangitis there, edematous. Stone eventually is impacted, which blocks the CBD. Subsequently, the stone floods and passes to the duodenum. So the jaundice appears, and when edema is subsided, jaundice disappears. That means there is a stone impacted, so again there is jaundice. So there are not too much time to decline the jaundice to the normal because there is another stone there, it again impacted there subsequently. Or the stone, when the bile is coming down, the stone is again impacted at the ampulla petal. For that reason, there is not, don't give more time to decline the jaundice to the normal. For that reason, that nature is called the fluctuating jaundice, which commonly causes is the common bile duct stones. Presentation is fluctuating jaundice. And another one is a progressive jaundice. That means gradually the increase the bilirubin, the jaundice gradually increase and never comes to the baseline, always increases, never go down. This is called the progressive jaundice. The commonest cause is carcinoma of the pancreas, because the carcinoma of the pancreas, it progressively compresses from outside to the opening of the common bile duct. That means common bile ducts and ampulla better from outside in the second part of the duodenum. So there will be complete luminal obstruction. Bile cannot exit through the CBD, results in progressive jaundice. So these are about the pattern of presentation of jaundice. So look, the head of the pancreas malignancy is there, it presses from outside. And there is a stone into the common bile duct, so that causing block the lumen of the ampulla. And there is a periampullary carcinoma. How can you evaluate the patient of obstructive jaundice? So that means you take the history. What is the history? That means the patient present with some nausea, vomiting. There may be loss of appetite, the right upper quadrant pain, fever with chills and rigor. It is a very important characteristic features of cholangitis. But that type of presentation also develop in case of urinary tract infection, in case of malaria. So these are the 3 differential diagnoses or fever with chills and rigor. That means cholangitis, urinary tract infection, and malaria. Then others are itching or pruritus. So you look the patient having some itching there, and high colored urine due to the bilirubin passes through the urine. Bilirubin For that reason, the patient having high colored urine, and stool is pale and clay colored stool, and some bleeding tendency. So obstruction causing the lumen of the guard having lack of bilirubin, stercobilirubin is lack. For that reason, the stool color become clay colored. It is the most diagnostic features. Some patient may present to you, the presentation say there is white color stools. So these are very important clarifying points to evaluate this is the cause of obstructive jaundice the patient having. Whenever the patient complains with itching, jaundice, itching, and stool color change. These three things is the main features. What about the general examination? In general examination, you look about the anemia, jaundice, sketch marks, and lymph node. So the lymph node is very important. One is, though the lesion having a carcinoma of the gallbladder or the head of the pancreas or periambulary carcinoma, that patient may present to a supraclavicular lymph node enlargement. For that is in case of obstructive jaundice, in general examination, you give more emphasis about the lymph node examinations. For that reason written here, the lymph node examination is mandatory in case of general examination of obstructive jaundice patient. Scratch marks is the supportive one. The patient having itching, so the scratch mark there. If the patient having a jaundice, so it represents that the patient having a jaundice is yellow color of the skin and mucous membrane. And if the patient anemia, which dictates that the patient may having a jaundice along with anemia, it may be having associated with malignancy, it may be a carcinoma of the pancreas or cholangiocarcinoma, etc. So this thing you can assess from the general examination. Look about the local examination. You inspect the abdomen, because in inspections from outside you look the umbilicus, shape and contour of the abdomen, visible lump. These three things is very important one. Because if the patient having a ascites, so abdomen is distended, the shape of the umbilicus is distorted. So that can dictate the patient having some ascites inside. You look and observe subsequent examination to confirm that the patient having any ascites or not. For that reason, look the umbilicus, shape and contour of the abdomen, and any visible lump or not. And on palpation, you look, there is a tenderness, rigidity on the right hypochondrium or upper abdomen, present or not. The liver, in case of obstructive jaundice, may be enlarged and tender maybe. This is due to the cholestasis. And gallbladder may be palpable in case of double impaction of the stone in the ampulla of bladder and the stone at the neck of the gallbladder, or the patient having a carcinoma of gallbladder, the gallbladder may be palpable, or may be mucosal, or may be empyema. That all the things there, that means the patient may having gallbladder is palpable along with the jaundice. So palpation is very important, takes part role to confirm or support to some extent of disease process confirmation. Then about the percussion. So that percussion is very important one is fluid thrill, shifting dullness. That two things can confirm that clinically the patient having ascites is associated with the obstructive jaundice. And another one is auscultation for bowel sound. So that bowel sound, usually there is a normal. In case of malignancy advanced stage causing some obstruction of the guard, in that case may having some high pitched sound, Bergman sound present. What about the investigations? So investigations tools are very simple tests: hemoglobin, total count, differential count of WBC. So in case of malignancy, usually the patient having maybe anemic, for that reason hemoglobin may be declining. ESR is raised in case of malignancy and chronic disease. So you can evaluate from the ESR there is some having a disease, having maybe a malignancy. And bilirubin, it is the important tools for confirmation of jaundice. Not only the color of the sclera and the skin, confirmed by looking the bilirubin level of the serum. In the exam, say the bilirubin examination from the blood or the plasma or the serum. Your answer is serum, not from the blood. So the total count, differential count from the blood, yes sir, but bilirubin examination is done from the serum. And another important one is alkaline phosphatase. It is very important one. In case of obstructive jaundice, we are always look the alkaline phosphatase level, because if it is raised, it is most likely the patient having obstructive jaundice. And another important thing is, always important is, if it is more than 3 times of normal value, then it is confirmed that the patient having obstructive jaundice there. More than 3 times of the normal value. Very important answer is more than 3 times the normal value. And HGPT may be raised, but the confirmatory one is the alkaline phosphatase one. And another one is the prothrombin time, because the liver is the factory to production of fat-soluble vitamins. From there, absorbed through the bile, absorbed through the enterohepatic circulation, to go to the liver and produce the coagulation factors. So if the coagulation factor is declining, like prothrombin time, then the prothrombin time is prolonged. That prolonged prothrombin time dictate the patient may having some impairment of the liver function. So one investigation is sufficient to confirm that impairment of liver function is prothrombin time. If it is prolonged, then the patient may having, there is a confirmatory to some extent that the patient having an obstructive jaundice. That means jaundice there, who is having an impairment of the liver function. And also give the serum albumin. Albumin is produced in the liver, so albumin globulin ratio is altered. If the albumin level is declined, then the globulin is increased, so the ratio is altered. It also signifies that the patient having some liver function impaired. Urinary bilirubin and urobilinogen. So urinary bilirubin, if there is also a diagnostic tools that the patient having to some extent of obstructive jaundice there. These are all indirect one, but the direct investigations are, look what is the cause of the obstruction is. Is there any obstruction? You can evaluate by looking some indirect investigations and direct one. So looking the picture, you can evaluate also what is the cause of the obstruction is. So the evaluation of the patient with obstructive jaundice investigations, imaging test. The imaging having 2 types. One is non-invasive imaging, and another one is invasive imaging. The non-invasive imagings are ultrasound of the whole abdomen with a special attention to hepatobiliary system and pancreas. So if the sonologist is good enough, we can give the total scenario of the hepatobiliary system. If the patient having a gallbladder stone along with CVD stone, all the patient having only the common bilateral stones, there is no gallstones, or what is the scenario, the intrahepatic and extrahepatic biliary trees are dilated or not. And head of the pancreas can evaluate very cautiously by ultrasonographically there is a lesion or not. So these are about the ultrasound findings of hepatobiliary system in case of obstructive jaundice. And that thing after ultrasonography you can evaluate by subsequently with the CT scan. So that CT scan can dictate that, particularly for malignancy, you can exclude by doing a CT scan. You can evaluate that there is a head of the pancreas lesion or not, if the patient having a cholangiocarcinoma or not, if there are any enlarged lymph nodes or not, if there are any ascites or not, if there are any liver metastases or not, if there are any carcinoma of the gallbladder or not. That can evaluated by looking the CT scan. This is the image system one. And another one is MRCP. Nowadays, it takes the more popular, the MRCP, magnetic resonance cholangiopancreatography. Sometime ask in the exam, sometime in the short note may present in the written examination. So what is MRCP? That means by doing the MRI, the biliary system is delineated by computerized 3D images. That 3D images can visualize the biliary systems, biliary tree. So the biliary tree, if there is any filling defect there, they can easily evaluate that there is a stone there is a worm there, and there is some, seeing the nature, sometimes they give the information that the cholangiocarcinoma is there or head of the pancreas there. So that 3D image reconstruction is possible only by a MRCP. So for diagnosis of obstructive jaundice, for seeing the dilatation of the systems very properly, if you do the MRCP, you can easily evaluate the evaluate the biliary, and you can evaluate the cause of the obstruction. The others are invasive imaging. That means there needed some introduction of some instrumentations inside the body, then push the dye and visualize the tree. Then the process is called the ERCP. That means by endoscopically, you look the ampulla better by a endoscope, which is called the duodenoscope, and looking the ampulla better, put a cannula, push a dye from the outside, and at the time of pushing the dye, take an X-ray on table by the C-arm and look in the monitor what is the lesion, how far the obstruction, and where the level of the obstruction is, and how far the dilatation of the biliary tree. That can easily take images by direct introduce the dye, throw the ampulla, and taken an X-ray image by the CR. This is called the ERCP. This is a diagnostic tools. Also, it also helps by doing the ERCP. It can take some therapeutic roles also. So therapeutic part we can discuss later on. And another one is PTC. That PTC transhepatic, percutaneous transhepatic cholangiography. That PTC having a more popular previously when the ERCP is not available, because the endoscopy facility were not available in that time. The biliary tree is dilated, so intrahepatic biliary channels also dilated. So from the outside, by ultrasonographically, they can detect the dilated intrahepatic biliary channel, and from the exterior directly put a needle inside the liver, and when the liver enters into the biliary tree in the liver, the bile is coming out, so confirm that the patient having the needle inside the biliary channel. Then introduce some dye, iopamiro, from the exterior and take an X-ray with the C-arm guided. So take the images. You can evaluate the dye is passing down, what is the level of obstruction, how far dilatation it is. But it is a more invasive procedure, and there is some complication. Invariably, the patient develops septicemia because the intrahepatic biliary channels, whenever dilated, there is more pressure. So whenever the piercing the liver tissue with the needle, the vascular channel are open. So that open vascular channel migrate the bacteria from the higher pressure of the biliary tree to the blood vessels, and subsequently the patient develops septicemia. For that reason, nowadays the PTC not routinely done. Very limited rules for diagnosis do the PTC. So this is about the investigation. What about the treatment? So the treatment depends upon the cause of obstructions. What is the cause? You evaluate first. Then according to the etiology, you can treat the patient. So before describing the treatment of the obstructive jaundice, I differentiate some jaundice. What are the presentation of various types of jaundice? That means the stone, whenever the jaundice is due to the stone, whenever there is a jaundice due to the malignancy, and some having a drug-induced cholestasis jaundice there, or medical jaundice, or acute viral hepatitis called the medical jaundice. So that can differentiate by looking some points tabulated there. So take the history. If the patient having a dyspepsia, having a biliary colic, most likely the patient may having a CVD stone. If both are not presentation, there is a nil, because the malignancy is slowly growing. There may not be symptom initially, only the jaundice there. For that reason, that symptoms are not there at the time. But in case of drug-induced, present the patient having some drug which are liver hepatotoxic, that taking the history, you can take that history and you can evaluate the patient may having some drug-induced cholestasis. Or if the patient having a transfusion, or they're having an injection, or the patient contracts. So these are about the viral hepatitis, maybe from the history. You take the history, there may be possibilities from the history, and you can more emphasize that investigate and subsequently confirm your diagnosis. So what about the pain? In case of pain, the patient having a colicky pain and epigastric to back, the reason is there. But in case of malignancy, also there is a pain in advanced stage when the head of the pancreas is infiltrated the surrounding nerves. There is a constant pain. So the pain is constant, epigastric to the back. And drug-induced, there is no pain. But in case of viral hepatitis, discomfort in right upper quadrant, because in case of viral hepatitis, the hepatic cells are swelled up. So the liver tissue enlarges, the capsule is stressed, so there is some discomfort or pain over there. For that reason, the acute viral hepatitis, the patient having some discomfort in right upper quadrant. What about the weight loss? In case of weight loss, in case of CVD stone, slight or not, because it is usually the acute presentations. But in case of malignancy, it is the late presentation. For that, it is more marked. And drug-induced slight, acute viral also the slight, plus minus. And pruritus is plus minus in case of CVD stone, according to the obstruction, persistent time, duration, the presentations. But in case of malignancy, always there is pruritus. In case of drug-induced cholestasis, so there is intracellular, there is a intrahepatic cholestasis, so there is a pruritus. And in case of viral hepatitis, the pruritus is transient. The investigation can dictate the cause of jaundice, is surgical jaundice or medical jaundice. That means in case of bilirubin, it is usually in case of the obstructive jaundice, CVD stone is 50 to 150 millimole per liter. In case of malignancy, steady rise to more than 200. But drug is variable, it is variable. And in case of urobilinogen in the urine, in case of CVD stone, but in case of malignancy, there is no urobilinogen because there is a complete obstruction. So urobilinogen is not production. So the patient does not have urobilin in the urine. In the early, in the late, there may be a urobilinogen absent because there is cellular edema causing some obstruction in the intrahepatic level. What about the alkaline phosphatase? This is the very important thing. It is more than 3 times, in case of malignancy, in case of CVD stones. But in case of drug-induced cholestasis, there may be, and in case of acute viral hepatitis, it is usually less than 3 times. What about the SGOT by ST? That means it is less than 5 times, it is 5 times. But in case of more than 5 times normal value, in case of viral hepatitis. About the WBC count, it is more, it is normal or increase, normal. But in case of viral, there is a lymphocytosis. And ultrasonography can dictate gallstones with dilated ducts. There is a dilated ducts with plus minus mass or stricture. There is a normal, there is some splenomegaly may be present. So these are about the differentiating points between the medical jaundice and the surgical jaundice to evaluate the various points. So the stone in the common bile duct, sometime asking the exam, what is the called stone in the common bile duct? It is called choledocholithiasis. Choledocholithiasis. The spelling everybody must know. Choledocholithiasis. So stone in the common bile duct, again, there is 2 types. Primary CVD stone and secondary CVD stone. It is not required for all students. It is required for those student needs higher marks. Sometimes at that time in the asking the exam. But in case of postgraduate students, it must be known in everybody's. So the 2 types are primary common bile duct stone and secondary common bile duct stones. That means the stone which is developed within the common bile duct. It is called the primary CVD stones. The stones which arises de novo in the bile duct. In infected bile, there is a nadus formation, ultimately stone formation. They are usually brown pigmented stones. Causes Pathology of the biliary tree causing stasis such as biliary dyskinesia, benign biliary stricture, sclerosing cholangitis, and choledochal cysts. So all are causing stasis. Stasis causing infection, there is a precipitation, and ultimately there is a formation of the stones. And infections, infestations like chronic sinusitis, scariasis, it also causing the stone formation there. So these are about the primary biliary stones. What about the secondary biliary stones? CBD stones means they migrate from the gallbladder through the cystic duct. Commonly, gallstones gets impacted in the supraduodenal portion of the CBD. That means the stone is migrated from the gallbladder, originate from the gallbladder, and go into the conveyor duct. So this is called secondary biliary stones. That means CBD stones. So some terminology are, there is some retained stones and the recurrent stones. Retained stone and recurrent stones. Retained stone means you do the surgery of the conveyor stones and there you left over there a stone there. You miss it during operation. So when the stone is found in the CBD within 2 years of operations, then your diagnosis is retained stones. But recurrent stone means you clear the stones from the CBD, you confirm it with the choledocoscope, then after surgery, whenever there is again stone form, then it is called the secondary recurrent stones. That means usually happen within after 2 hours, 2 years of operation. Within 2 years is the retained stones, and after 2 years is the recurrent stone. But recurrent stones may develop too early, maybe. So the clinical presentation. The symptoms, the patient may be asymptomatic. Usually one or more of the following symptoms are present. That means pain is similar to pain in the cholecystitis, means upper abdominal pain. There may be colicky pain there. And jaundice is usually fluctuant in type. Fever with childhood rigor indicates the acute cholangitis. Signs, tenderness may be present in the epigastrium of the right hypochondrium. Gallbladder impalpable. Usually a patient with CBD stone has fibrotic because the patient having chronic cholecystitis. So the patient gallbladder has become shrinkage and is not distended, non-distensible of gallbladder. There is a presentation triad, which is called the Charcot's triad, a sign that represents acute cholangitis. It comprises intermittent pain, intermittent jaundice, and intermittent fever. Pain, fever, jaundice, all are intermittent. Then it indicates that the patient having obstructive jaundice. It means having a cholangitis there. So it is called the Charcot's triad. There is one law invariably asked in the exam or in the OSP may be present, Curvaceous law. The law is in patient with jaundice, if there is a palpable gallbladder, it is not due to the stones. Whenever the jaundice patient having a palpable gallbladder, we are always think that the patient may having a carcinoma at the pancreas. Obstruction is other than stones. There is a gradual obstruction there, so gradual distension of the gallbladder, accommodation of the bile and distended and palpable, painless palpable gallbladder, which is called the palpable gallbladder, which is most likely diagnosed as carcinoma of the pancreas. But in case of stones, there is a pain. But in case of gallstone, there is a chronic cholecystitis, the gallbladder is receding. But that law is not all the time maintains. There is some exception of the law is, if the stone is impacted, one stone is impacted at the neck of the gallbladder, another stone is impacted at the ampulla bladder, so there is a double impaction. So one impaction causing jaundice and one impaction causing stasis of the bile in the gallbladder causing distension, mucosal empyema formation. So that are the causing the gallbladder become palpable. For that reason, the exception of this law is double impacted stone, that is one in the CBD and one in the cystic duct or neck of the gallbladder, with causing mucosal of the gallbladder. So large stones in the Hartmann's pouch causing obstructions, and the patient develops mucosal of the gallbladder or empyema of the gallbladder with CBD stones. These are about the fallacy of Curvaceous law. So diagnosis of obstructive jaundice of stones, you previously described liver function test, ultrasonography, CT scan, MRCP, and another one is, it is important one, is endoscopic ultrasonography. That means put an endoscope in the second part of the duodenum, first part of the duodenum, second part of the duodenum. So through the scope, there is a probe there. Within a scope, there is a probe. So by that probe, you can take an image in the monitor looking like an ultrasonography picture. What about the CVD diameter, stone is there or not, easily validated. It is more clear delineated because very close contact with the CVD with the endoscope. For that reason, endoscopic ultrasonography. In future, it takes important role for diagnosis whenever it is more available. It is very limited available in Bangladesh. Only one center is Dhaka. The others are ERCP for diagnosis and treatment. And lastly is the PTC. It is both diagnostic and therapeutic purpose. It is done if failed, ERCP. In that case, it may be done with the PTC to some extent. So show the picture. This is ultrasonography. This is a common bile duct. There is echogenic structure and also give the shadow. So echogenic structure casting acoustic shadow in the line of the common bile duct. For that reason, this is CBD, cholelithiasis. So bright echogenic structure in the common bile duct casting posterior shadow. CBD diameter is more than 8 mm. Though this test is not specific enough to diagnose CBD stones. It is not the specific confirmatory. It is supportive. So look at the picture. This is the CT scan. So it is the most sensitive investigation for CVD stone. It shows stone location, ductal structure, block, ductal dilatation, intraepithelial challenges, easily evaluated. Look, this is the gallbladder is distended there. There is a stone into the neck of the, that means in the ampulla better, there is a stone there. So that can they can easily delineate that there is a obstruction there and also an obstruction there. For that is the gallbladder is distended. In subsequent film, you can evaluate there is a neck stone there. So this is endoscopic ultrasonography. So endoscoping, having a probe, so that give the information more delineately there is a stone there. So it is useful and accurate, but it is in basic procedures. It is useful in taking biopsy from a mass. FNSE can taken by that endoscopy possible through the common bile duct, directly enters inside the lesion and takes some needle FNSE and biopsy to some extent. From a mass if found to exclude cholangiocarcinoma. So this is about the MRCP. So the billet is reconstructed with the images. So look, it is a right hepatic duct, it is a left hepatic duct, common hepatic duct, this is a common bile duct. In the lower end, there is a black area, which is hypo-intense area. It means it is non-invasive investigation which delineates biliary anatomy and pathology clearly. It is not therapeutic, it is diagnostic. Low signal filling defect in the CVD, which represents stone surrounding by a high signal bile. The bile is high signal and stone is low signal. So it is a black, it is a white. So this is about the ERCP, endoscopic retrograde cholangiopancreatography. Everybody must know that abbreviation because frequently asked in the exam, endoscopic retrograde cholangiopancreatography. It is invasive investigation which identifies the pathology, site of the blocks and stones. It is also therapeutic purpose. Single or multiple stone filling defects can seen by looking the picture. So through the endoscope, they push the dye, take an X-ray with the CR. So the biliary is delineated because the dye is entered inside the biliary. So where there is a stone, there is black filling defect there. So 1, 2, there may be 3 stones there. So multiple stones can easily delineated by ERCP. And also you can assess the size of the stone also. So what about the complication of CVD stone? Because sometimes some patients are neglected. They go here and there. take some Kabiraji or Hamdard medications and came to you with a very late stage. So in that cases, the patient presented as a prolonged obstruction causing impairment of the liver function, which in some cases may progress to biliary cirrhosis. Very late cases in that cases. If it is not treated properly, subsequently the patient develops biliary cirrhosis. Sometimes there is a long-time obstruction causing white bile formation. Due to the bile is absorbed, which remains in the common bile duct. The mucus is secreted from the lining epithelium, accommodated there, and due to the mucus derived from the glands lining the ducts following large ductal obstruction, and the patient having a white bile formation. And where there is a stasis, there is an infection. So infection causing suppurative cholangitis. And if a single duct is obstructed, two ducts is obstructed, or three ducts obstruction, the patient may develop subsequently there is a liver abscess. Or there is a stasis causing infection, that infection go into the blood, the patient presented to you with a complicated septicemia. And sometimes the stone is passes through the ampulla better, the ampulla is distorted, then the reflux of duodenal content go enters the pancreatic duct, the pancreatic enzyme become activated and digested the pancreatic tissue, which is called the pancreatitis. If the stone is near a sphincter body, blocking the drainage bile, pancreatic duct, ultimately whenever it is lost, it becomes disrupted, the lumen become distorted, and the patient present with the pain, that means pancreatitis. So how can you prepare the patient before going for surgical treatment? Because a lot of complications may develop if you don't treat the patient, resuscitate the patient fast. If you resuscitate fast properly, then the complication of after operation is less. For that reason, preoperative preparation of an obstructive jaundice is mandatory. That means should be prepared preoperatively at least 3 days. It is not the mandatory one, but depends upon the severity of the disease. That means IV glucose, IV fluid you prescribe. So, or if the patient can take orally, encourage oral glucose, oral fluid, oral carbohydrate fluids intake more. And dehydration should be corrected fast. Electrolyte should be corrected. If the patient has evidence of cholangitis, IV antibiotic started. And if the patient having a prostomy time prolonged, it is must be needed to correction to some extent. Otherwise, the patient bleeds after surgery. That correction is done by intravenous quinaquion, that means vitamin K injection. If you give injection quinaquion IV, so that drug passes through the blood to the liver, and there is that vitamin K can produce prothrombin. That means vitamin K dependent factors are produced there. Or if there is any emergency surgery needed in that time, that vitamin K, it takes time to the formation of vitamin prothrombin. For that reason, in that time, fresh frozen plasma, if you prescribe the patient, infuse the patient, it can easily recover the prothrombin. So early can do the surgery. So in the exam, ask whenever a patient takes time, how can you correct it the prothrombin time? The answer is I advise the patient injection vitamin K 10 milligram in adult patient IV daily for at least 3 days. Or in emergency, I can prescribe the fresh frozen plasma. The another thing is a mannitol. That means it is one type of diuretics. It is also prevention of hepatorenal syndrome. It is also very important topics. Hepatorenal syndrome. Whenever you do the treatment of a obstructive jaundice patient, in the post-operative patient, the patient may develop hepatorenal syndrome. So during surgery, before surgery, you always cautious about for prevention of hepatorenal syndrome. For that reason, correction of fluids and assessment of the urinary output preoperatively. Then you go for surgery. Then there is a less chance of development of hepatorenal syndrome. So sometimes some mannitol may prescribe during or just before operations. Hazards of operation of a jaundice patient. What are the hazards happen? First thing is more bleeding. That bleeding is due to the deficiency of clotting factors, that means prothrombin, which is vitamin K dependent factors. So vitamin K is absorbed from the terminal ileum. So due to the vitamin K depletion factors, BTCT and prothrombin time is prolonged. So there is a chance of a development of obstructive jaundice. Development is a chance of bleeding because the prothrombin time is prolonged. So you correct it fast. Impaired resistance to infection. It is important one thing. Whenever the patient having a jaundice, there is the immune system also suppressed. So correction of infection, patient develops post-operative septicemia. For that reason, perioperatively you may prophylactic antibiotics start. So the liver is sick, so there is less glycogen storage. That glycogen can increase. Perioperatively you can infuse some glucose. And the kidney function is impaired is due to the bilirubin, which is filtrate through the kidney. It blocks the renal tubules. So if you give some forced diuresis, so there is a less chance of hepatorenal syndrome, renal failure development. So preoperative preparation is mandatory in these cases. So hepatorenal syndrome is features of renal failure is a jaundice patient without pre-existing renal disease within 24 hours or during operation is called the hepatorenal syndrome. The mechanism is obstructive jaundice causing the bilirubin is raised. So bilirubin is deposited in the glomerular membrane and acute tubular nephritis develops. The acute renal tubule becomes blocked, so acute renal shutdown, and the patient develops hepatorenal syndrome. What about the definitive treatment of CVD stones? Lot of options are available, but the gold standard treatment is ERCP. That means endoscopic retrograde cholangiopancreatography. Put an endoscope into the duodenum, side view endoscope. The endoscope made two views. One is end view, another one is side view. The end view endoscope for upper GI endoscopy, for looking the esophagus, stomach, fundus, duodenum, etc. But in case of ERCP, it is needed to side view endoscope, which the name of it is called duodenoscope. Examine the duodenum. So medially there is a scope lens, so medial wall can easily delineated in the picture. For that reason, the scope name is side view endoscope. So endoscopic sphincterectomy and stone extraction. So by an endoscope, the sphincter of body is divided, so the opening is wider. Then put an dormia basket over there. So the stone is catched by the dormia and pull it down to the duodenum. Or sometime introduce some balloon catheter, which is called the Fogarty balloon catheter. That means very fine channel with the balloon, collapsed balloon is introduced through the common bile duct, go up, observing with the X-ray, that means serum, then inflate the balloon and push it down. So under the balloon, if there is any stone, it can expel out through the opening. It is called the balloon extractions. So either dormia extractions or the balloon extractions. If the stone is too large to clear look, then it is very difficult to negotiate because the ampulla better is sphincter opening is not more opening form possible, because if you more cut the ampulla, so there is a chance of duodenal perforations. So for that reason, there is a limitation of sphincterectomy. That means the sphincter is divided at the ampulla. Above the ampulla, there is a mucosal fold. So up to the fold, they are divided, because if you go beyond the fold, there is a chance of duodenal perforations. So if the duodenal perforations occur, the life becomes hell. So it is very difficult to manage the patient. For that reason, in large stone can manage by an expert center. Through the endoscope, they put a basket, dormia basket, and catching the stone with the dormia. Then there is a mechanical compression, the stones, the stone become crushed. Then remove it out, the dormia along with the stones fragmented. So this is a high technology, which is not possible by all the surgeons or endoscopists. It is a special training needed. and expertise needed, and there is a more chance of injury to the cord by that. So it is very challenging game for a large stone. So for the large stone, you can treat by other means, open one on laparoscopy, one is better. And if there are multiple stones present, the stone is too large for extractions, then placement of an endoscopic pigtail stand. That means during ERCP they fail, they don't possible to do it further. So at that time, for relief of obstructions, they put some endoscopic stand, which is called the endoscopic pigtail stand. So that stand can help prevent the complete obstruction of the lumen, so the jaundice become declining, and subsequently you go for other methods of treatment. Whatever you choose, you go for subsequently after relieving the jaundice. And once CVD stones are extracted through ERCP, then you must need it to do the cholecystectomy subsequently. Easily done after 48 hours, because within 24 to 48 hours after ERCP, there is a chance of pancreatitis development. So it takes time for assessment, is there any pancreatitis or not. If there is no further pancreatitis, then do the laparoscopic cholecystectomy in the same settings. So treatment of CVD stone, one is ERCP, one. The another one is most popular for all the surgeons of general surgeons. They are long time they are practicing, which is called the open cholecystectomy. So this is not too much challenging surgery like ERCP. It very easily can done. So during open cholecystectomy, so first they open the abdomen, subcostal incision or midline incision, whatever they choose. Then the common bile duct is identified, giving two stents which are there, confirm with the syringe that there is this common bile coming out from the duct, then open it. This is called the cholecystectomy. And after opening the common bile duct, the stone is removed by using the Desjardins cholecystectomy forceps are introduced, and pull it out and keep it in a gallipot on the trolley. Subsequently, make a wash with the normal saline, then clear the CVD, and after that, the clearance is confirmed before closing the CVD is needed. For that reason, introduced confirmation of the duct clearance is done superiorly and inferiorly by cholecystoscope or by cholangiography. That cholecystoscope may be flexible one, may be rigid one. There are two types of cholecystoscope, one is flexible, one is rigid. Whatever available, you can do it. If there is nothing is available, cholangiogram, if do, at that time needed to do C-arm on the operation theater. If it is not available there, so in that case, it is very difficult to do the cholangiography. We can, whenever the cholecystoscope and the cholangiography facilities are not available, in that time we confirm it, we put some bougie dilator through the cholecystectomy wound and fill at the surface of the duodenum second part, the tip is filling through the ampulla or not. If tip is filling, then it is confirmed that there is no obstruction is there. Or sometimes we put some catheter there and wash with the normal saline. If the duodenum is inflated, that indicates that the ampulla of bladder is better. These are the alternative methods where the facilities are not available. In that cases, we do it. Then after confirmation, there are two options. One option is you just primarily close the CVD and put some drain and close the abdomen. And another option is more safety, put a T-tube in the common bile duct and put some drain on the peritoneal cavity and close the wound. And after 14 days, do an X-ray, confirm it and remove it out. So this is about the T-tube and CVD open cholecystectomy management. But whenever you go for CVD exploration, there is some indications when you go for CVD explorations. So we go for CVD exploration in that time when the ultrasound dictate that there is stone in the common bile duct, one, or during open cholecystectomy, there you remove the gallbladder and palpation of the CVD with the fingers, 2 fingers. So that palpation, that evidence that there is a stone in the CVD. So at that time, you must need it to go for CVD explorations. And whenever previous is written there in the books, Whenever the dilated CBD, giving the information of the ultrasonography, the dilated CBD. So at that time, you need to evaluate the CBD by explorations. Recent history of jaundice with elevated alkaline phosphatase. And whenever failure of stones, extraction by ERCP. So if you do the ERCP, they are not possible to remove the stones. In that time, you go for the lithotomy. And another more important thing it is, whenever a single faceted stone in the gallbladder, it is very important one is, facet indicates that the patient having more stones there. So without more stones, there is no facet develops in the stone body. So the facet picture indicates that there is another stones there. So if the gallbladder is empty, only single stone there, in that case, there is more chance to more stones migrate to the CBD and stay there, which can miss in the ultrasonography. For that reason, in that cases, single faceted stone in the gallbladder can dictate you must open the common bile duct during open cholesterol. The other options are, nowadays in big stones, and most of the patient does not allow to go for a big incision. So the alternative options are laparoscopic cholecystectomy. This technique requires considerable laparoscopic expertise and it is time consuming. So it can be alternative procedure to failed ERCP and is surgeon dependent. Additional surgical procedures are, sometimes the stone is not possible to negotiate from the ampulla of Bader by an ERCP or by a laparoscopy. In that cases, there is needed to do the transduodenal sphincteroplasty. That means sphincter of body, you open the duodenum, ampulla of Bader is opened up, stone is removed, then the ampulla of Bader is closed, the mucosa, duct epithelium and the duodenal mucosa, then it is called the sphincteroplasty. And other options that are additional options are like choledochoduodenostomy and raw and white choledochojejunectomy. These things are addition to choledocholicotomy, or whenever the failed to do remove the impacted stone from the common bile duct. That two things causing some definitive bypass surgery needed, because if you don't go for bypass surgery, there is not relieve the jaundice. Because if the stone is left in the ampulla of Bader, which is not possible by any means, open surgical or the ERCP in the laparoscopy. So at that time, the patient must be needed a bypass for the draining the bile. So that bypass is done by the choledochoduodenostomy or raw and white choledochojejunectomy. That means duodenum, make an incision over the duodenum and stitch with the common bile duct bone, or raw loop is made and attached to the common bile duct. So the raw and white choledochojejunectomy made. But that two things usually given, easily made. In that case, this is normally done if the CBD is dilated more. So more dilated CBD, having there is a chance of recurrence again. So for recurrence prevention, sometimes we go for some definitive bypass surgery. Or the patient has multiple CBD calculi with distal narrowing. So there is a chance of stone formation again. In that case, you can do it. Or there is a so much narrowed ampulla of Bader papillary stenosis, or the stone is impacted, which is not possible to negotiate. In that cases, we go for a bypass surgery, which is called the choledochoduodenostomy or raw and white choledochojejunectomy. So what about the treatment of the retained stone? What about the treatment of the recurrent stones? So do the surgery, put a T-tube. After doing surgery in the post-operative period, whenever you do the T-tube, post-operative T-tube angiogram, reveals that there is a stone left there in the ampulla of Bader or the CBD lower end. So if you remove the T-tube, there is a chance of obstruction and obstructive jaundice. So you treat the patient after confirmation that CBD stone left there, so that confirmation can dictate you what type of treatment you go further. So you put a T-tube there. So the T-tube, whenever you put inside the body of the common bile duct, put our place outside. So there is a tract surrounding the T-tubes. there is a collagen tissue deposition due to inflammatory collagen tissue is deposited there, and there is a tract from the skin to the common bile duct. So after 14 days, whenever you remove the T-tubes, if the facilities are available, you can introduce the cholecystoscope through the skin wound to the common bile duct and hold the stone with the Dormia basket and extraction through the tract. If the facility is available, you can do it. Or if there is chance of ERCP facilities, then you can do an ERCP and remove it out. Then the tube is removed. Or if the T-tube absent, in that case, you go on for ERCP extraction, or everything fails. Not possible, not facilities of ERCP, not facilities of cholecystoscope. In that cases, you can go for the cholecystectomy or transduodenal sphincteroplasty. In case of recurrent stone, ERCP is the stone extraction is the first line of choice. If the duct is dilated more than 2 cm, stone is more larger in size, in that case, you go for the cholecystectomy or Rowan-Y cholecystectomy or transduodenal sphincteroplasty. So look, this is the T-tube. The appearance likes a T, for that reason the tube is called T-tubes. So the T-tube is placed within the common bile duct. The one end is exterior. So the bile is passing through the T-tube is down to some extent come through the tubes to the exterior. So this is the T-tube end in the body, the outside. So how can you manage the T-tubes? So these are in the OSPE question, sometimes asked written OSPE question, or sometimes asked in the Viva, how can you manage a T-tube? So this is a very favorite question for the examiner. That means post-operative management of T-tube. So the T-tube causing the bile passes through the tube to the exterior. So drainage of the bile through the T-tube after the 7th postoperative day. Up to the 7th postoperative day, uninterruptedly, no clamp is there. Subsequently, you clamp the T-tubes. From the 8th postoperative day, you started clamping the T-tubes and observe if there is a free flow of bile, so there is no obstruction, no pain, no fever, etc. If there is an obstruction with the stone remain there is or the edema is there, so there is a stasis causing some distension and causing some pain, discomfort, sometimes fever. And daily observe the bile flow, the quantity of the bile flow is declining or not, what is the color of the urine, and what is the color of the bile, and is there any leakage or not. And postoperative T-tube cholangiography is done is 11th postoperative day. So clamp the T-tubes overnight. In the morning, they do an X-ray in the X-ray department, push the dye from the T-tube external end, IFM dye is pushed, the X-ray is taken. So that X-ray can confirm that there is any filling defect or not, there is any gastro or not, and the free flow of dye in the duodenum, that can confirm that there is no remaining stone there. Then you remove the T-tube. On 14th postoperative day, just you pull it or sustain, make a traction, the T-tube is removed out spontaneously. If you put some traction, only little bit traction can remove it out easily. And patient general condition is satisfactory, jaundice has subsided, urine stool color normal, LFT become normal, then you are satisfied, the T-tube is removed and discharge the patient. So this is about the post-operative T-tube cholangiogram. So that T-tube cholangiogram showing both extra and intraoperative biliary is well delineated, normal in appearance, free flow of dye into the duodenum. And to some extent, the pancreatic duct is also visualized there. So this is the findings of T-tube cholangiogram. If there is a stone there, so there is a filling defect in the common bile duct, then your answer is stone remains at the CVD in the lower end, filling defect there. So here, there is no filling defect, free flow of dye, well delineated the biliary tree. So this is about the ERCP. So look, the patient on a lateral, that means prone position, and face is turned on the left side. So this is the monitor for looking the endoscopy picture. And there is a C-arm, X-ray C-arm machine. So whenever the image is taken from the X-ray machine, give the X-ray beam and take an image, which is go there over the X-ray monitor. So this is about the RCP machine. Then this is
endoscopic retrograde cholangiopancreatography is performed using a side-viewing duodenoscope.
Not the end.
The scope is passed from the patient's mouth through the esophagus and stomach to the descending portion of the duodenum. A wire-guided sphincterotome is advanced through the scope to the site of the major duodenal papilla. Cannulation of the major papilla.
So first, that is called a cannulation. Ampulla better, there is a mucosal fold. So up to that level, they can cut. So first, introduce the cannula. This is cannula. Introduce the cannula. Then from the exterior, they push the dye and take an image in the C-arm and look about the biliary tree. And after that, this is more introduced. This wire, if you turn and with the electricity current, this endocard option, that wire can burn the tissue and cut the tissue over the sphincter and open the sphincter, which is called the sphincterotomy. Look carefully how the sphincterotomy is done.
Is performed with the wire-guided sphincterotome. The position of the guide wire in the bile duct is secured, and the sphincterotome is advanced over the guide wire. The sphincterotome has a cutting wire that is used to cut the biliary sphincter segment using electrocautery. This opens the orifice of the major papilla to allow stone retrieval. A large stone has been identified fluoroscopically. A dilating balloon is used to further open the orifice of the major papilla to facilitate retrieval. The stone retrieval balloon is shown here in the lumen of the duodenum. The deflated balloon is advanced into the bile duct and positioned above the most distal stone. The balloon.
Look, the balloon, collapsed balloon is passing beyond the stones. We're looking the fluoroscopy X-ray. Then inflate the balloon, then pull it out.
The balloon is then inflated and used to sweep the stone out of the duct. The retrieved stone is shown in the lumen of the duodenum.
So this is about the ERCP. That it is the peculiarity is in case of stomach, in case of the colon, whenever we do the polypectomy or the etc., we can remove it out. But in case of duodenal ERCP CVD stone, whenever we remove, we just pull it out and place in the duodenum. We don't able to remove it out through the duodenoscope to the exterior. It passes with the stool subsequently. So look, there is a CVD exploration. So introduce the laparoscope and identify the convoy duct and give two steps which are there. This is laparoscopy choledocholisotomy. Then the surface is divided, anterior surface is cut with the seizure. Look. So while they split out, look, there is a stone. So with the forceps, it can remove it out. So more stone is there, subsequent stones are removed out. Wait a bit, look, there it is the laparoscopic view and it is the choledocoscopic view, but it is not introduced the choledocoscope. I introduced there the ureteroscope. The rigid ureteroscope is introduced through the epigastric port, enters inside the CVD, opening choledocotomy wound, and go downwards towards the ampulla better. And ampulla is negotiated, ultimately looks at duodenal picture, duodenal lumen. Look carefully, that is rounded one is the choledocoscopic view of inside the convoy duct, and this is the laparoscopic view. Simultaneously, both the camera are on. So both intra and extra body can easily seen. Confirm it. Then placement of the T-tubes. So this is the placement of the T-tubes, and choledocomy is required. This is laparoscopic choledocholidotomy. What about the biliary sclerosis? So, the biliary sclerosis is diagnosis and confirmation and treatment. The diagnosis, clinical features, typical features of obstructive jaundice. That means fever, jaundice, and rigor may be present, colicky pain, etc. So ultrasonography can easily tell it that there is a tubular structure within the CVD which can more or less confirmatory that there is CVD1, and which can also confirmed by the MRCP. Look, there is a worm or not. If there is a worm there, so the worm moves there and causing the sphincter become contraction and there is more pain. So for that reason, the treatment, conservative treatment to some extent may be practiced. That means antispasmodic. If you prescribe the antispasmodic, the sphincter body become relaxed. So there is a chance to worm again return back into the small intestine. Or some anti-emetic drugs, if you prescribe subsequently, the worm become die. But if the dye inside, it is not possible to expel out. So worms can also be extracted. Whenever it is not relieved by spontaneously the conservative measure, then it needs to evacuate by to some extent of surgical measurement, like endoscopy one or the surgical one. If the endoscopy facility is available, it is better. No need to any open abdomen, no need to any incision. Just during ERCP, they introduce the balloon inside the lumen and make it pull and expel out the worm. So worms can be extracted through the ampulla or better by ERCP. Or surgical, either laparoscopy or the open one. Whenever there is no facilities of ERCP is available, in that time, go for the surgical treatment like open or laparoscopy. But there is again chance of re-infestation of the worm. For that reason, prevention is mandatory. After doing the extraction of the worm from the CVD, the anti-emetic drug prescriptions routinely, it must be prescribed to the individual. Otherwise, again, the patient presented with obstructive jaundice. So look at the laparoscopic CVD extraction, which is done by me in the private clinics. So choledochotomy made, then worm is held up with the forceps, with the meridian forceps. Then the worm is pulled out through the choledochotomy from the gallbladder, from the CVD to the peritoneal cavity, and after it expel out through the port. Sometimes there is a more worm may be present inside the lumen. For that is an ultrasonography and MRC very delicately you can evaluate. Otherwise, you can miss one CVD stone, another one remains there, left there. So what about the biliary stricture? So biliary stricture having some causes there. It could be a congenital one, that means narrowing of the CVD, or bile duct injury. The bile duct injury, it happens during cholecystectomy, it happens during choledochotomy, or it happens during gastrectomy or hepatic resections. At any time, it may develop, and that injury healed, and subsequently there is scar tissue. Scar tissue having a tendency to contract and narrowing of the lumen. And some inflammatory conditions like CVD stones causing inflammation there, and subsequently there is maybe a stricture, cholangitis, parasitic infestation, pancreatitis, sclerosing cholangitis after radiotherapy, and some malignant condition like cholangiocarcinoma. The terminology of cholangiocarcinoma is carcinoma of the common bile duct. It's called the cholangiocarcinoma. Carcinoma of the gallbladder is called carcinoma gallbladder. But whenever the malignancy arises in the common bile duct, it is called the cholangiocarcinoma. And after trauma and idiopathy. So that stricture having some classifications which can dictate what treatment can do subsequently. That means low CVD stricture with the stump. If the proximal to the stricture, that means there is a stricture is proximal to the common bile duct is more than 2 centimeter. So there's enough stump you can repair very easily. For that reason, low CVD stricture, the stump proximal to the stricture is more than 2 centimeter. It is called the Bismuth classification of 1. In the 2, when there is a middle, at the middle there is a lesion, the stricture is proximal to the stricture is a stump is less than 2 centimeter. And level Bismuth 3 is when the stricture is the hilar region. It means right and left hepatic duct regions whenever the stricture is called the Bismuth 3. And when the stricture is separated right and left hepatic duct separately, it is called stricture 4, Bismuth 4 classification. And Bismuth 5 is involving the intrahepatic ducts. So these are the Bismuth classifications of strictures. These are not required for the undergraduate students. These are required for the postgraduate students. So investigations more or less the same, like ultrasonography, LFT, MRCP, ERCP, on-table angiogram, and PTC. So treatment, if it is a narrowed, possible to negotiate the lumen, then do an ERCP and put a stricture, put a stand there. So that stand can relieve the stricture for subsequent times, 6 months, 1 year, the stricture segment become relieved by standing. But if the stricture is there, proximal part is dilated, it is very easy to do the bypass surgery like choledochoduodenostomy or Roe and Y choledochoduodenostomy or hepaticoduodenostomy. These are the ideal treatment. But if the duct is not dilated, it is a very challenging to bypass surgery done, and subsequently there is restrictions develops at the new site of anastomosis. So these is the very dangerous situations for the treatment of the stricture of the biliary tree. So thank you all. Thank you for patient sharing, for elaborate description of the obstetric jaundice. Now the session is open for question session. Do you have any question to ask now?
Assalamualaikum, sir.
Islam?
Sir, can common bile duct burst open in any cases like ascariasis or CVD stone?
In case of ascariasis, it is not needed to open. If the ERCP is facility is available, you can do an ERCP and remove the worm by ERCP. And
I mean, sir, can the CVD anytime burst?
no, there is no chance of burst. It is very difficult to burst, like gangrenous gallbladder. No. It causing complete obstruction, back pressure changes over the liver. There is a jaundice more, pain more, fever more, etc. But there is no chance of burst in case of worm in the CVD or stone in the CVD. There is no chance of burst the CVD.
Thank you, sir.
Any more question?
Assalamualaikum, sir.
Aslam?
Sir, after ERCP, after extraction of the stone from the bile duct into the intestine, sir, as it is removed by the stool, sir. So, is there any chance of obstruction in the intestine by that stone?
No, because day after the last day we described about the gallstone ileus. The gallstone ileus having a criteria, the stone size must be more than 2.5 centimeter. By ERCP, never ever we remove the stone more than 2.5 centimeter. Because if we remove the more than 2.5 centimeter as it is, we needed to more opening the sphincter. So whenever there is a 2.5 centimeter sphincterotomy done, there is a chance of duodenal perforation. The patient does not survive subsequently. So that stone is usually smaller in size. If there is a big stones there, they can broken with the mechanical lithotripter and broken in smaller pieces and remove it out. So all the stones are smaller in size. So there is no chance of possibilities to develop intestinal obstruction subsequently after removing the stone through the ERCP. Am I clear?
Yes, sir. Thank you, sir.
Thank you. Any more?
Hello, Assalamu alaikum, sir.
Islam?
Sir, my question is, in biliary stricture, if we do ERCP stenting for and keep it for 6 months, then will there be any complication?
Yes. Not only 6 months.
1
Usually
year.
the stent are functioning 6 months to 1 year. Usually, because
Yes.
the stent having some sedimentation and crustacean may block. So if it remains there, there is chance of again block, and again there is a obstructive jaundice. This is the one complication.
Okay, sir. Thank you.
So any more question? So if no more question, today we conclude the session. Our day after tomorrow, the next session is the diseases of the spleen. Because spleen is a vital organ for every individual. So be carefully, we can read it. So day after tomorrow, we can discuss about the spleen and its diseases. So thank you, everybody. Thank you for precious sharing. Thank you.
Thank you, sir.
Thank you, sir.
Welcome.